Welcome to this most recent episode we have of the Accad Koka Report. Today we have the pleasure of having Dr. Stanley Goldfarb on. Dr. Stanley Goldfarb this is his second time appearing. He is a former dean of at the University of Pennsylvania, and he is here to talk about what he's been up to since his last appearance. Unlike most of us who spend our time idly tweeting, he's actually been producing quite a bit of substantive work, as is evidenced by the fact that he's written a book that recently came out that I was, again, unaware of till recently. And he has a fantastic op-ed in the Wall Street Journal that just came out that also talks about what is near and dear to many of our hearts, and that very, very few people in medicine can actually talk about. So we're here to have Dr. Goldfarb tell us what he's been up to. Welcome to the show.
Well, thank you very much. It's great to be back. And I've been following you all carefully over the years and appreciate the work that you're all doing. After my op-ed back in 2019, I received a tremendous onslaught of criticism, you may remember, from Med Twitter. That in fact led to the Wall Street Journal writing an editorial about that. That was an early attempt at cancellation. There's not much of.
Yeah, this is 2019. So let's rewind. And so it's been a while. I can't believe. Can you believe it? The pandemic has happened. Tell us tell us about the op-ed and tell us about that. Why it resulted in.
Yeah, well, that op-ed was about my concerns, which had built up over the years, about the fact that medical school had really been evolving into a much less rigorous experience for many students, and B, had become an increasing emphasis on teaching social issues in medical school under the assumption that social determinants of health was a real phenomenon and that physicians should learn about that, and which I felt was fine to learn about social determinants of health. But the problem at the time was I saw it as becoming an increasingly large portion of the medical school curriculum, which I thought was a mistake, particularly combined with what I believe is a less rigorous experience. So I wrote this op-ed in the Wall Street Journal about it. The reason, it was sort of an interesting story how it came about. There was actually an article in the Wall Street Journal about the fact that so many medical schools were teaching courses in climate change. And I wrote a letter saying how ridiculous I thought that was. Not that that may not be a real phenomenon. I just didn't see the role of physicians in altering the CO2 content of the atmosphere. And they said, well, we weren't aware of that article. The editorial page wasn't aware of the article, but I pointed out that there really was such an article. And they said, oh, that's interesting, but why don't you write an op-ed about this? And so that's what led me to do that. And then Twitter just exploded after I wrote the op-ed about what some of the words that were used was that I was an asshole. That was one of the milder terms used, and so on. And that led the Wall Street Journal to writing another op-ed, because after my school sort of came out and said that they were for diversity, equity, and inclusion, my op-ed had nothing to do with diversity, equity, and inclusion. And that my views did not represent those of the medical school. That further ignited the fire on Twitter. And so after that sort of calmed down, I decided that my best effort should not be to start to troll people on Twitter, but actually should be to expand on my thoughts about this. And that's what led me to write the book. So I spent the last year and a half writing several versions of the book until the book came out. Now, the op-ed, one of the reasons the op-ed created such a stir was the title, which was "Take 2 Aspirins and Call Me by My Pronouns," which was a title generated by the Wall Street Journal, not by me. I actually objected to it because I thought, it's just sort of needlessly inflaming things. And then when I wrote my book, the book publisher insisted on keeping that title. And I offered him maybe 25 alternate titles, but that was the one that we had to use. So the title of the book is the same. And so I spent quite a while writing this book. And after I finished the book, I sort of had discussions with some friends and other folks. And it became quite clear that if we were really going to do anything about this, that we needed to form an organization that would have some clout. And we got some people together and we formed this organization called Do No Harm. And this organization is a not-for-profit. And that was the focus of this Wall Street Journal op-ed that appeared on Tuesday. And the goal of Do No Harm is to become a mechanism for those in the healthcare world and others who are concerned about this idea that, which is an expansion of the topics that I wrote in the op-ed, but similar to some issues that I wrote in the book. This idea that sort of wokeism, to put a phrase on it, has entered the world of healthcare. And what is that all about? Well, when George Floyd was killed, there suddenly was this sort of awakening in America to its racist past and also to its racist present, which was the claim that was made. And anti-racism became the watchword for medical schools and for other healthcare institutions. And for example, my institution, Penn, decided that it was irredeemably racist and it had to eradicate the racism that made up aspects of the current health system. And specifically that disparities, which are well known to affect the Black community in general, that these disparities were at least in part due to bias on the part of physicians and racism in the care of patients. And Do No Harm, this new organization, is specifically devoted to combating that notion. We don't deny that there are disparities, and we don't deny that there may be people who harbor racist feelings. We do deny that the healthcare, that the physician workforce in the United States has contributed in any kind of a substantial way to the poor outcomes or the disparate outcomes that Black patients suffer. And so Do No Harm is devoted now to being a voice for those physicians who want to oppose this idea that anti-racism ought to be implemented in the healthcare world. Because anti-racism, according to Ibram Kendi, means discrimination. He has said that past discrimination should be dealt with through future discrimination. And, there have been some really striking examples of how this has actually been implemented. So, for example, New York City decided that the use of scarce monoclonal antibodies, at the time scarce, for the treatment of COVID-19 should be preferentially given to individuals of color rather than white people, because this is what's required to make up for past discrimination against Black patients. And, and then what's been most recently been uncovered is the fact that in the latest Medicare regulations, the federal government has declared that it will pay Medicare physicians in the Medicare system an incremental bonus if they develop a anti-racist protocol in their practice. And it all flies under some of the general theories of of anti-racism, which are that quality is a zero-sum game. That if we provide better quality care to one group of people, we have to provide less quality care to other groups of people, and specifically to develop a healthcare system that favors one group of individuals based on their skin color. I guess I don't know how else they're going to decide it compared to other individuals. So Do No Harm is devoted now to combating all this. And how are we going to do it? The first thing we're going to do is we're going to sue the federal government next week over this Medicare rule, which we feel is discriminatory, and it will be announced next week that we're going to go ahead and do that. We're also providing a tip line for individuals who call in and write in, and we've gotten literally hundreds of tips about circumstances that people find appalling that they've experienced in their own healthcare systems. Some of these we can help them with in terms of helping them in having legal backing for some of these. These may be lawsuits that we will take on. And we also intend to expose to the public the fact that this issue is brewing in healthcare, and more and more it's going to undermine the quality of healthcare, because if allowed to go unchecked, more and more issues will be dealt with this way. Let me give you one more example, which I think is particularly noteworthy. There was a study done up at Harvard of the fact that African-American Black patients who would come into the emergency room needing treatment for heart failure were being preferentially admitted to the general medical floor as opposed to cardiology services. This study of this topic was done, according to the authors, famous academic clinicians, through the lens of critical race theory. They use that phrase in the method section of their paper. And what this study purported to show was that Black patients had a substantially greater chance of being admitted to the general medical floor, whereas white patients had a substantially greater chance of being admitted to a cardiology service if they came in with heart failure. And the solution that they came up with to this was that Black patients would be offered a choice of which part of the hospital they would be, which service in the hospital they would be admitted to, in order to compensate for these past failings, supposedly, of the Harvard hospitals, the Peter Brent Brigham in particular, Brigham and Women's Hospital now. However, when you look at the study itself, what it turned out that the reason for this discrepancy was the characteristics of the patients, not their skin color, but their medical problems. The Black patients tended to be dialysis patients. So they were coming into the hospital with heart failure because of volume overload. They were getting admitted to the medical service, presumably because their treatment was going to be in more intensive dialysis treatments. The white patients had a greater incidence of valvular heart disease. So they were being admitted to the cardiology service because presumably there was the kind of approach that was needed to treat them there more effectively. Putting patients who need dialysis on the cardiology service is possible, but it's much more awkward than putting them in the general medical service. Now, New York, one of the authors of this study became an assistant health commissioner in New York City, and it was brought this idea to New York City, and I'm not sure they actually implemented, but again, they were going to admit in New York City hospitals, in the New York City health and hospital system, they were going to admit patients preferentially to the cardiology service if they were Black patients. Now, part of the reason they thought it was a problem being admitted to the general medical floor is that the patients who got admitted to the general medical floor for heart failure tend to get readmitted to the hospital more frequently. But of course, you know, those of us that care for dialysis patients understood they got readmitted to the hospital more frequently because the problem was their difficulty in handling any kind of a fluid challenge because of their end-stage renal disease. So this is an example of this anti-racism run amok in the healthcare system and attributing disparities in care and disparities in outcomes to physician bias, when in fact that really wasn't at all the basis for this. So that's what Do No Harm is. It's going to be an enterprise that fights against the notion that the problem for Black patients with poor outcomes and disparate outcomes compared to white patients is because of bias on the part of physicians. And let me say one more thing before I let you guys ask me questions about this, is that what's the problem with all this? So what? So what's wrong with going ahead and having this kind of response? And the problem is that it really undercuts healthcare. It undercuts healthcare for Black patients, because one of the great problems is clearly mistrust by the Black community for the healthcare system. And it's quite clear one of the reasons for the very low uptake of COVID-19 vaccinations amongst the Black community has been this distrust. And there are individuals who have been out there trying to fight against this and try to educate the fact that these vaccines are necessary in order to control the epidemic, which apparently has been pretty well controlled anyway at this point. And I think undermining that trust is terrible. And I think all of us, who have cared for Black families, I can think of one family that I dealt with caring for patients with end-stage kidney disease. They had a young son that had end-stage renal failure because of glomerulonephritis. And the parents just didn't trust anything that we said, anything that we wanted to do. And it really interfered with the care of this young man. And, so having good trust between the physician and patient, particularly in the face of serious illness, is critical. And this kind of verbiage about, we're a racist healthcare system and the physicians have been biased, and that's why outcomes have been less than optimal for the Black community, I think is a very, very dangerous notion and really needs to be combated.
Dr. Goldfarb, the term wokeism is sort of broad and can encompass a number of different things. Critical race theory is a big part of it, but there are other issues, including gender and transgender, matters, perhaps climate change, perhaps others as well. Most of your book tends to be, is focused primarily on this critical race issues and the claims made of racism. Is that also where your organization will focus its efforts on, or do you think it'll be broader in terms of helping people navigate through the landmine of transgenderism and feminism and all these other gender-related things, and perhaps even climate change and other things of that sort?
Yeah, the transgender issue obviously is a very, very difficult problem, and it's kind of given the number of people that are really struggling with their gender identity, it's sort of become an outsized issue, I think. We've talked a lot about it amongst our group, and I think one thing is that we feel pretty strongly about at this point, acknowledging that we're not experts in this area and we don't care for these patients. And I would say that I make the point in the book, the only point about gender in the book is that when I was the head of the curriculum at Penn, we had a whole day devoted to transgender health. We brought in experts who were actually treating transgender individuals because we thought the students needed to understand what treatments these patients that they would see might be on, and what some of the psychological as well as the physical and physiological issues were that these patients had to confront if they were on various hormonal therapies and so on. That's for adults. The thing that really disturbs us has been this idea of getting children into hormonal treatments, puberty blockers, even surgeries in the pre-adolescent and even in the teenage years. And it's quite interesting that the European countries, several of them have now decided that they're not going to support that kind of activity. And the reason for it is that we just don't have the data to show that, in fact, it's beneficial. And the myths that have grown up is that there's a high suicide rate that would be eliminated if children that decided that they had gender dysphoria were treated for it. But, gender dysphoria is a fairly common phenomenon amongst young children, and then it tends to sort of disappear as they mature. And the idea that once a child identifies that this is an issue for them, and suddenly they're put on medications that can change their hormonal status, is something that, again, several European countries have rejected. And if there is an issue in this whole idea of gender medicine, that's the one that we feel fairly strongly on. We've worked a little bit with Abigail Schreier, who's been a leading journalist who's led this way. Her book, Irreparable Damage, about the issue of exposing children to these treatments, is something that I think we feel strongly about. And again, it's not a question of us making some sort of moral judgment about it. It's from a scientific standpoint, the data just aren't there to say which children actually might benefit from this. It may very well be that there would be such circumstances. We just don't know who they are, and we don't know what characteristics they have, the ones that would benefit. And we don't know what the outcome is in any sort of rigorous scientific fashion for the ones who do undergo some of these treatments, the reversibility of it and so on. So that's sort of our position in that area. We're against children being exposed to this, given the fact that there's such a dearth of data about the outcomes.
So I think, I mean, your book, I did read, it was a page turner. I read the whole book yesterday. It was and you really, I'm really impressed by, the how much work you put into it, and how you've laid out the argument. But, one of the fundamental things that you try to push back on is this idea that physicians need to be focused on more than just the patient and the diseases that are afflicting them right now in their exam room or in their hospital room, right? What has taken over much of medicine, certainly in academia, is this idea that we do need to be paying attention to the societal problems that may have landed the patient at the door. So, and to be clear, you don't deny, certainly, I mean, you don't deny the fact that there are inequities that exist in society. There's privilege that people are born into for whatever reason that are going to result in better outcomes for one group versus the other, correct? What you're saying is that, look, if you want to solve a transportation problem, go into something that'll solve the transportation problem. Me as a nephrologist, it is probably beyond my scope necessarily to fix some of these larger issues, right?
No, yeah, I'm sorry.
Am I summarizing that generally? Okay, your argument?
Oh yeah, of course. This idea of the social determinants of health, there's just a huge literature out there about this, and the literature is based on the notion that living in less than ideal circumstances is a cause of poor health. What's never clear is exactly what the mechanism of that is. What is the mechanism of living in a suboptimal setting, or living in a neighborhood that has a high level of violence, for example? How does that make you sick? Now, one of the arguments is it makes you sick because you're under more stress. But then again, a lot of people are under stress. You probably had a pretty stressful day seeing patients. The so-called privileged individual who's suddenly in terrible financial straits is also under a lot of stress. I'm not sure that the catecholamine system is differential in that way. So that's one problem with the social determinants of health. There's no question that there are clear associations between these social circumstances and poor health outcomes. What's missing is the mechanism. And as you point out, what's missing is agency on the part of physicians to do anything about these social circumstances. Now, I have to say that as a nephrologist, one of the big problems that we dealt with all the time was transportation, because we had to get patients to the dialysis units to get their treatments. And the way we dealt with this is we had social workers. So we have every hospital and certainly every large nephrology practice has a social worker associated with a dialysis unit, because we're aware that we need to worry about the social circumstances of the patients. But I don't need to become an expert in transportation issues. I don't need to become an expert in combating violence in order to say to the patients, look, I'm worried about you, and I'm going to refer you to the social worker who's going to help solve the problems that can be solved through social work.
Right.
They're much more.
Paul Farmer, right, is one of the fathers of. By the way, Paul Farmer was at Penn, correct? I'm not as familiar. Well, I don't know where he was, but do you know Paul Farmer? Did you know him personally, or?
Well, he died. So
no, he recently passed away, correct? And
he was at Harvard. He was at
he was at Harvard.
He was the head of.
So anyway, he would be one of the fathers, I would say, right? One of the ideological, certainly somebody who was out front and kind of convincing people about this, right? And so, and what I know a little bit about Paul Farmer is his wonderful story on going to Haiti, right, and trying to take care of patients who have pretty significant diseases that people don't necessarily die of here, so tuberculosis, and I think what he was pushing back at was this idea that, look, I'm in Haiti, I have tuberculosis medicines, the patient is here, here's the tuberculosis medicines, and he'll have patients that get treated for TB or given some medicine, they go home and they die, right? And the immediate impulse for most people is to say that they're dying. They died because they didn't believe in modern medicine. They went to some witch doctor or something like that, or they died because they didn't have it was some they were poor or whatnot, and so the barriers were economic. But and so I think Paul Farmer actually did a trial in Haiti where he randomized. The therapy was not just tuberculosis meds. The therapy was giving transportation, giving money so that they could come there, right? And the folks that were given money and were given the ability to access the clinic, he reduced their mortality by 60% or something like that, correct? So, and there's an example somewhere, I forget where I read it. Lisa Rosenbaum may have written about it. She's the NEJM correspondent who writes wonderfully about lots of things. But she this idea that if you have a patient who wants to leave against medical advice, right? And the first impulse is to blame the patient for, not understanding that they need to stay. They have an ischemic limb, say, right? And they need to stay, get treatment. Otherwise, if they leave, the next time they come back in septic shock, and then something terrible happens. But when you sit and ask why the patient wants to leave, it turns out that he wants to smoke, and if you got him a pack of cigarettes, he would stay, so that you could then treat him the way you need to treat him. So that's the argument. The argument is, if we simply talk to patients about, you need to be on Plavix, you need to be on aspirin, we need to get you on something to decrease your proteinuria so your kidney disease doesn't progress. We're talking around the issues, and the fundamental issue is, hey, I'm not going to stay in the hospital unless I get, smokes, or I'm not going to, you get what I'm saying. So yeah, so tell me, so what's the...
Well, the real answer to this is the undergraduate education of physicians in the humanities.
Right.
So they understand humanities. I even have a little brief section in the book, how if every physician were forced to read Shakespeare, read The Merchant of Venice, read Lear, read Hamlet, you would have tremendous understanding about many of these issues. Even reading Lear itself would really benefit you. So what you're describing is an individual who's sensitive to humanity, is willing to listen and communicate with patients. And again, I think courses in how you communicate with patients is really important. And we did teach that at Penn. We continue to teach that at Penn. The question is, where does it end, though? The question is, do we need to have now some sort of curriculum about anti-racism? Do we need to say that the reason that these patients get into difficulties because of physicians' bias? Or do we need to say, look, I was a pupil of George Engel. George Engel was one of my preceptors. He was the father of the whole idea of the biopsychosocial model of health. We learned that we didn't have to occupy, 4 years of medical school learning these issues. And I think simply telling a few stories about how patients are in need at times and how you need to talk to them and find out what their problems are doesn't mean that you have to have a 200-hour curriculum in social issues, getting into all kinds of racial issues, all kinds of other cultures, their medical issues, and all that, in order to understand the problems. And I think, yes, of course, we need to have well-educated individuals who are physicians. The question is, where does that end? And more specifically, the question is, what do we tell our patients? The problem here is the communication to the patients, that the reason that, they're getting poor care, or at least having poor outcomes rather, is because of the way they're being treated by physicians who are biased against them. That's
You're right, and let's spend a little time, because I think your book does a great job of looking into the research behind all these claims, right? The claims that the doctors are racist and so forth. So tell us a little bit about this. The whole theory of implicit bias and what's behind it and how it came about? Because right, they're not claiming that you know, that we're intentionally racist or whatnot, right? There's this claim that it's implicit or and so forth.
But again, just to point out, the folks that sit on one side, you know, the folks that want social justice, the folks that are opposed, they believe that you know, on your prescription pad should not just be ACE inhibitors and whatever. They believe that on your prescription pad should be, you should be able to write for loan forgiveness. You should be able to write for you know, money for you should be able to write for a companion, right? To go with you. So you should be able to write for a social worker to go home with somebody to visit them and whatnot.
Well, you can do. You certainly can write for a social worker,
right.
not so. You do all the time. I mean,
right. But is your point, Dr. Goldfarb, that is a point is one of the main points that, and there's so many points, there's so many things, but is one of the main points is that as a physician, and I think you make this point about why a lot of this comes from the primary care sphere, right, versus the specialist sphere, is the point that, like, you know, the individual physician just simply does not have the bandwidth to be able to be both a good clinician, to be able to understand the disease process and how to treat that medical side of things, as well as do all this. I mean, you can't be the social worker, the transportation person, etc. Like, that's just an impossible task. I mean, if is that one of the reasons?
Otherwise, what's the point of having social workers? I mean,
right.
These people spend 2 years going to school, learning all of the ways to deal with city bureaucracies, to all of the you know, other organizations that help
right.
You know, support socially in the community. They're the ones who are responsible for this. If we have a family that comes in and their child is ill, they have the Ronald McDonald House. These are all set up by social services that do this. And sure, physicians should be aware of this, but again, how much of this should go on? Should the curriculum be, well, we're going to cut back on our teaching of physiology this year because you need to learn more. That is what's going on.
Right.
That is,
and the thing
what is in
right.
medical school.
Yeah, and the thing is that this idea. I mean, again, I trained at Temple in North Philly. You spent much of your life in West Philly. These are both areas with zip codes that low socioeconomic status, minorities that do poorly. So, and this has been part of, you know, there's this idea in some of the physicians I see that are coming up that are very vocal that this is not something that, you know, you and I are somehow attuned to, that we don't understand that there's a bunch of other issues that are going on in these particular patients, or that somehow we're opposed to that. I think this has been going on, and I've been telling residents and I've been telling medical students when I was at Temple about the fact that, oh, you know, make sure we ask about this and this, because, you know, we have to figure out how to get this person safely home, etc. So that was always part of the team discussion, this idea that, like, oh no, we never were discussing these things. I mean, I don't know where that comes from. And I think one of the reasons that you wrote what you wrote now, you know, 2019, is that it's not just what Paul Farmer was saying. What Paul Farmer started out saying in terms of being aware of this stuff, that's been part of the medical lexicon for anyone with training in places like Temple and Penn, certainly, right? But there's something that's drastically changed recently. It's gone well beyond be aware of what's going on and try to sort this out and try to come up with, you know, sit on some committee where you come up with some structures to do this. That's been going on forever, you know, but something changed. And you described one example that to me was shocking as a cardiologist, right? And it's exactly what we talked about. The article that was written in the Boston Review about how to move beyond just understanding and speaking to the issues, but actually go and then try to create equal outcomes, right? And this idea that you had to now, and this is a huge fundamental change and shift, which goes well beyond anything that I've spoken about so far, right? move to a place where you have to be color conscious. Like for so long, we have tried to be color blind, correct? The problem is for folks on the on the one side of this issue is that despite taking a colorblind approach, despite that being impregnated in our legal system, or at least that was the understanding, outcomes have continued to be very disparate between certain groups and other groups. And so now, in order to fix that, you have folks that are writing, folks from Ivory Perches, writing very clearly that offering preferential care based on race or ethnicity may elicit legal challenges from our system of colorblind law. But given the ample current evidence that our health, judicial, and other systems already unfairly preference people who are white, we believe, that our approach is corrective and therefore mandated. We encourage other institutions to proceed confidently on behalf of equity and racial justice, with backing provided by White House executive orders, and it links to something that is an executive order from the White House talking about advancing racial equity. Right. And so that's a huge shift, and I think it's important to say that's why folks like you, others, me are increasingly uncomfortable, because it if you want equity, if you want racial equity, you're starting to get to a place where you have to be very color conscious, and if you're color conscious, you're now suddenly discriminating based on color, which is exactly what it's very hard for me to understand how that Boston proposal to admit patients to a certain service that is believed to have better outcomes. If you do that by race, where you preferentially put for certain groups based on I guess what they're saying their race is, if you put them into a service that has better outcomes, how is that okay? How is that not discriminating? It seems like we are right back to where we were in the 1960s before the civil rights movement.
I think part of this is an example of, we see an illness and we don't understand it, and what we do is prescribe a treatment for it. And that's what's happened here. There's a problem. There's a problem of disparate outcomes, and we've prescribed a solution for it without understanding the mechanism of it. In the Boston study, the mechanism of this disparate utilization of services is not biased. It turns out to be actually an optimizing of the way the patients are cared for. And my thesis is, and which I think is, you can show over and over again, that the diagnosis, no one has really understood the mechanism. They've identified an illness, they've identified a problem, they've come up with a solution for it, and the solution is not going to solve the problem because they're not treating the real underlying issue. And if the underlying issue is social conditions, well, you better fix the social conditions. If the underlying issue is physician racist behavior, fine, then fix physician racist behavior, but that's never really identified. And the more that you look at it, the more you look at these studies, the more you think about them, you understand that what's going on here is a sort of a concerted effort to create a narrative that it's racist behavior on the part of healthcare systems and physicians, because it's like the blind man, the drunk who loses his keys and goes looking for it under the light bulb because that's the only place he can see. The only thing that healthcare systems can do is say, okay, now we have racist behavior and we're going to get rid of racist behavior. They're not going to change anything. Outcomes are not going to change if we send every physician in the United States anti-bias training. Nothing is going to change because that's not the problem.
So back to Michelle's point. To Michelle's point now, this is now leading into Michelle's point. So, of course, the pushback will be to say, Dr. Goldfarb, you don't know what you're talking about because there is so much evidence to suggest that racism in medicine is what causes these poor outcomes.
But then you have to look at the evidence.
Yeah.
And when you look at the evidence, which I've done over and over again, the evidence just isn't there. And it's actually really worse than that, because when you look at the evidence that people cite, particularly journalists cite, it turns out they don't even report what's in the study. I'll give you one example. After my op-ed came out in the Wall Street Journal, Axios came out with a sort of a rejoinder to it. And the reporter there came up with 4 or 5 examples of recent studies that pointed out that there was bias in the healthcare system, and her conclusion was maybe people are just getting tired of hearing this. And what I'm sort of doing is giving voice to the fact that people are bored with this notion, and that really that's why there's opposition to it, because of boredom. Well, one of the studies that she cited is one that she claimed showed that in neonatal intensive care units, that Black women found that the physicians were disregarding their concerns. This is what she wrote. So I pulled out the paper that she was citing. And this paper was about matching 16 Black women who had children in neonatal intensive care units versus 16 white women who had them, and then gave them a survey and asked them, how do you feel about the way you interact with the physicians who are caring for your baby? And in fact, the data were just the opposite. The data said that the Black women and the white women really felt that their voices were listened to. They called it efficacy of voice. And there's a quotation, I wrote back to the reporter, there's a quotation that says the women felt exactly the same in their questionnaire about how their voices were being heard. There was one other way that they really didn't match the women for educational background, wealth, anything like that. They just matched, compared them based on their race. When they took into account the incomes of the 2 groups of women, they felt that the Black women felt worse about the situation than the white women who had a greater financial access than the Black women did. So the study had nothing to do with disregarding anybody's concerns. The word disregarding is nowhere to be found in the study. The title of the study, to get back to what Michelle was asking about, was Implicit Bias in the Neonatal Intensive Care Unit. They didn't measure implicit bias, yet that was the title of their paper. So here we have 2 examples of the sensationalizing of some results, which show different attitudes on the part of Black patients compared to white patients, and making the conclusion that this article shows that the neonatal intensivists don't disregard the concerns of Black women, which there's absolutely no evidence in the paper to even suggest that. And the implicit bias part is a reference to the implicit bias test that you were talking about before. And the implicit bias test is an absurdity. The implicit bias test, which one can take, one can go online. There's a Harvard website. Test was developed almost 25 years ago now by Harvard investigators. And the implicit bias test is just totally unreliable. It's unreliable because if you take it 2 or 3 days in a row, you get 2 or 3 very different answers about whether you're biased or not. And the mechanism of the test is basically to show images of white people and Black people, to show words on the screen, and how quickly you relate the word to the image is an index of your bias. So if the word handsome pops up and you apply that more quickly, half a second more quickly to a white person's image than a Black person's image, that means you're biased against the Black person. And it turns out that when people are asked about why they made these choices, sometimes it's because they feel, oh, Black people are always treated poorly, and that's why so in fact, it indicated the opposite of what it was thought to have indicated. But the real problem with it is it's unreliable. It's unreliable. And it also suggests that we don't have any free will. And even if we have some sort of inborn prejudices against people that look different from us, the real question is, what do we do about that? How do we act? Do we treat patients poorly because they look different from us or they speak with an accent? Is there anybody in the world who does that? I'm sure there is somebody, but have you ever done that? I've never done that. I've never consciously done that. And if there was an unconscious bias that I had, it never entered the way I try to treat the patient. I tried to do the best thing I could for that patient. I've never seen a circumstance where somebody really tried to hurt the patients. That maybe they didn't understand what they were saying. That's an argument for having better communication skills. But this idea that bias is part of the story because of some ridiculous test that's irreproducible is just an absurdity. And yet, if you read the literature on racism in medicine and you start to go back through the citations to find the basis for statements that are made, such as it's well known that there's implicit bias on physicians' parts, you end up with studies that are almost meaningless if you go back to the original citations. And sometimes you have to go 3 or 4 or 5 layers of papers back before you find the genesis of a particular statement about bias or about some other aspect of physicians handling patients poorly.
Right.
So
there's clearly a disconnect between the quality or the level of the evidence and the certitude with which the people who embrace those ideas, push them forward and believe it. I mean, I certainly think that we can't really explain this on sort of typical scientific, sociological scientific terms. I mean, this is, it seems to me that it's, we live in right, there's evil in this world, and people are, have grown, certainly in the last several decades, it's a more and more secular society that doesn't really have any explanation for what the cause of evil is, right? Because the religions have sort of been pushed aside. And so now you have this theory that has the cloak of, at least the veneer of scientific weights behind it through these implicit test biases that provides an explanation for a lot of people who have grown up or gone to college, without any kind of deep reflection about questions of at least no reflections that are habitual in their lives about, evil and good and God and spiritual things, that now have this explanation about racism that really seems to cover everything, because you can you can fit everything into it, right? I mean, if there's implicit bias and implicit racism that explains why the world is bad, then it seems to make so much sense to a lot of people that they can overlook the lack of scientific, right? I mean, if you start criticizing the scientific evidence that is a proof that you're right, it's your implicit bias that is
well, I understand. I mean,
right.
that's part of whatever you say, whatever you do, you're racist. I mean, that's the Kendi idea about this.
Right.
But look at how far society has come. I mean, who's pushing hard about some of these issues? And that's a large cadre of Black physicians now, Black medical students that are present, Black faculty members. And yeah, the numbers aren't exactly matching the numbers of Black individuals in the community, but boy, I mean, look how far we've come as a society. I mean, take gay marriage. There was Barack Obama saying, he doesn't support this. And nowadays, does anybody even think about this issue anymore? And what is it, 5 years later? I mean, it's a society that, if anything, is moved in the opposite direction of what these people are talking about. And to me, it's just an absurdity that in a society that's becoming more and more humane, we're being told we're less and less humane, when the evidence just points in the exact opposite circumstance. And I think all that's going to come out of this new, explosion of the American awakening about racism is going to be further separation of the races, further mistrust by Black patients about going to see white doctors. And this is not going to do them any good, because the real issue is for them to get good access to medical care. And if good access to medical care means going to institutions that have a lot of white people working there, so be it. That's what's more important to them than this sort of crazy idea that physicians are actually contributing to these disparate outcomes.
Right. Now, you use a term in your book. You call yourself, I think, towards the end, as a neo-traditionalist.
Yeah.
Right. So in a way, I mean, you want to turn the clock back to how it was 20, 30 years ago, or tell me a little bit more about.
I think there were 2 threads in my book. One thread was about this idea that we've just been talking about, the development of these ideas about racism in medicine. And the other idea was about medical education. And I think, they've really come together. this greater emphasis on these social issues in medical school has really helped pour gasoline on this fire of institutions calling themselves racist. So the neo-traditionalist part is really talking about correcting what I think are the real deficiencies in medical education. I think these students are being given a second-rate medical education in general, and almost the place that they're actually learning to be doctors is in their residencies. They're not learning enough in medical school. Many medical schools now have cut back the amount of basic science teaching to a year. It's just impossible to teach this explosion of information that's occurred about the basic mechanisms of disease and the mechanisms of therapies in so short a period of time. Everything is given such short shrift, and then they're put into the clinic for a year, given this survey course in medicine, basically is what it is. And then the fourth year ends up being totally unstructured with a bunch of electives and maybe a few requirements, and then they go off to residency. And when you talk to residency program directors, and there's even data on this in the literature, a large proportion of students, even from the best medical schools, are really unprepared into their basic medical knowledge. So the tradition that I think we need to return to is that medical education needs to be really rigorous. I think we're charging them astronomical amounts of money, and we're not giving them a product that's worth the $200,000, which is the average debt of a medical student in the United States when they leave medical school. So I'm just calling for, and I'm sure I'm screaming into the wilderness here, the need for ramping up medical school. And the other thing I think is, and I make the point in the book there, that if you go back and look at medical student attrition rates from years gone by, they were much higher than they are now. They were something on the order of 8 or 9% when I was in medical school, and they're down to less than 3% now. That means there are a lot of people coming out now that would not have come out of medical school. Now, the question is, what does that mean? Does it mean that we're just doing a better job of selecting people? I doubt that. The ratio of students to spots, to applicants to spots, is about the same. It's about 2 to 1, 2 applicants for every spot in medical school over the years. There are many more students. There are many more medical schools now. I think the difference is that we're bending over backwards to make sure that every student who gets accepted into medical school finishes medical school. And how much of that should go on? At some point you need to say, yeah, this probably is a person that this is not the right thing for them. And the more and more that we dilute the standards of medical education, the more we're going to turn out people that are less qualified to be physicians. There's no way around that. And this, of course, has been the issue with this push for diversity, and the idea that Black patients need to have Black doctors is part of the underlying myth here. And the idea that if we turn out more physicians that resemble America, whatever that means, that we're going to turn out better physicians. And that's just, on the surface of it, that's just sort of crazy. And then it does make the presumption that the only way that Black patients are going to get the kind of care that they need is to have a greater cadre of Black doctors. There's a big literature about that. And the literature is so minimal. And we could talk about the studies that suggest that if you have a concordance of the race between patient and physician, that there's better outcomes. The largest study of this that was ever done was a meta-analysis about 57,000 patients in various studies, and found no difference in the outcomes of care whenever it was measured between if physicians and patients were of the same racial makeup. There have been a couple of small studies that, again, we could talk about if we had the time to show that it's inclusive. So that's my neo-traditionalist, is to go back and say, look, only the people that are qualified to be physicians ought to be physicians. We ought to have testing that goes on in access to medical school. We ought to have testing that goes on to decide who should go into the most competitive specialties. And we should not pretend that it just doesn't matter. Once you get into medical school, it's fine that you can be a doctor, and it really isn't that hard to do the work, when it's in fact is not true.
Right, perhaps, but one problem one could raise, or maybe I would raise, is that scientific competence or technological competence by itself cannot be the answer. And in fact, I would argue that the seeds of where we are now were planted back then, where you had predominantly, where the predominant focus was on scientific development, if we go back, 30, 40, 50 years ago, with lip service given to moral issues or ethical issues. And 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 then, problems occurred. And I don't think we should, view the past with, I don't know that you do that, but, view the past, through rose-colored glasses. There were big problems back in the 70s and 60s and 50s, right? I mean, the Tuskegee, experiment was a, people trying to be scientists at the expense of, it was the Public Health Service, I should add, right? It came from the Public Health Service. But there was that. There was, a number of things where I think in general there was a sentiment which is correct. You mentioned Illich. Ivan Illich in your book in negative terms. I think he's a complex character, but I think that we should pay attention to some of the criticism that was placed. I mean, there was a sense in which people felt they were being treated a little bit, very mechanically by this medical profession that had acquired a lot of privilege, right, and was sort of moving forward with its technological advances. There's another thing that to me is close to my heart. I argue with Anish about it a long time. But in the 1960s, the medical profession decided that people with a severe brain injury who are permanently comatose should be called dead, and that's it has essentially taken over. We have this concept of brain death so that we can use the organs for transplantation. I think that's a huge problem. I mean, right now there's backlash against that, and I think it's correct, but it's a very big deal that the medical profession, with a lot of technological and scientific know-how, can start doing these things, right? And if it's unfettered, so there's an importance, I think, for a moral framework to guide the scientific enterprise. So I don't want to denigrate. I think clearly the competence is very important, but there has to be an ethical background.
Yeah.
You call your organization "Do No Harm," which is obviously it's a reference to the Hippocratic Oath. You talk about Hippocrates in your book, and so how do you see these two things? I mean, I don't know that we can go back to just saying, we just need technological competence without understanding what the
what I'm saying is that medical school ought to be a place where you learn scientific competence. The question is, what's a well-educated individual? What are we getting into medical school? I think a well-educated individual will be someone who is sensitive to ethical and moral issues, is a moral person.
But would you make that part of the Hippocratic Oath was essentially an entrance exam, and so you had to make a pledge, right, an ethical pledge, whereas we have not for many decades. I mean, we do it, but it's sort of pro forma. It doesn't count. So I'm not saying that I have an answer. I don't know how you can do this sort of at a state level and impose sort of an ethical framework on people. But I think,
What I'm arguing about for medical school is spending more time learning to be a doctor, spending more time, right, not cutting medical school into 3 years or 2 years. We tried that once before. It was a big failure. And what's going on now is basically a 3-year medical school with a tremendous degradation in the amount of basic science that's taught. None of this precludes spending time learning ethics. That is an important part of the profession. I think it derives from the Western tradition of the Enlightenment and the literature and the philosophers that grew under that and over that time. And I think it's very important that students be educated in these areas and have a strong, undergraduate curriculum. This was what Flexner really pushed for, that medical students would be college graduates, and college graduates ought to learn issues like that. Their courses should not be just in women's studies. Their courses should be broadly in the humanities. And medical school should spend much more time than it currently spends teaching students science. For example, I don't think students should go in the first week in medical school into clinics, which is something that goes on. This is plain doctor. The argument is, well, that way they'll understand the rationale for why they're learning basic science. Come on. These are adults. Most of them start medical school when they're 23, sometimes even 24. They don't need to be given some incentives to learn the science. They need to learn the science. If they can't learn the science, they shouldn't be physicians. That doesn't mean they shouldn't learn ethics. And I learned ethics. I went to medical school, almost 60 years ago now. I learned ethics in medical school then. I just learned it. It took 4 years for me to learn the stuff that I was supposed to learn. And there was much less to learn then than there is now even. So that's really my argument of medical education. And I do think that this incremental 5 or 6% of students that would not have graduated back in an era 50 years ago that are graduating today is a concern. The exams are watered down. Every student is preparing for exams. That's what they do. They just do multiple exam questions all the time. UWorld, every one of these devices that are out there for them to pass their boards. And I show some evidence in the book where these preparation courses really dramatically ramp up ability to pass these exams. And I just think we're turning out students that are a lot of them are wonderful students. A lot of them work hard. There's a tail of students that we're letting through now that we shouldn't be letting through. They're not all African Americans, but the standards are down for everyone. So there are plenty of white students that shouldn't be passing through medical school that are passing through it now. And you talk to any residency program director, and they'll tell you the same thing. I mean, there are students that are coming out that just really are very weak, and then they learn a trade, they learn a craft in their particular sphere that they go into. How good they are, I don't know. Board passing, what the board passing rate in nephrology was 98%. An exam that 98% of people pass is like a useless exam. You're not testing anything. And what the goal is testing minimal competence. I don't think that should be the goal in our medical workforce, should be minimal competence. But that's what's going on. So part one of the boards used to have a score. Residency programs used to be able to use that score to determine whether students would be successful residents in competitive programs in specialties like neurosurgery and so on. Nowadays, there's no score it's a pass-fail exam. And this is the sort of degradation of standards that's occurred.
No, I think it's a lot of great points.
Yeah.
And I think one of the really, really important points in terms of just rewinding back to what you said before about the evidence base for that proves racism exists in medicine, and that lays all the blame for disparate outcomes on systemic racism, is that the research is incredibly flaky, and that's being kind. So the same folks that are guardians of truth, of objective truth, and the moment there's an ivermectin paper that comes out, there's they descend like vultures and say, oh my God, clearly, this is wrong and this is wrong and that is wrong. These papers come out that are identified as proof, and the usual suspects, or the guardians of truth, they're completely silent, right? And partly it's because if you say anything against, which is partly why I commend you, Dr. Goldfarb, if you say anything against that, this powerful narrative that has so much, it just has captured the imagination of folks to such an incredible extent. If you say anything against it, you were cast as being bigoted, as being a racist, right? It was really disappointing to read, for instance, that Paul Farmer. So with the Boston, preferential admission for Black patients to the heart failure service, right? There were, that got a lot of attention, and there were folks that apparently picketed in Brigham and Women saying, with banners that were
white premises, yeah.
Yeah, and Paul Farmer wrote an op-ed, and he co-wrote an op-ed in the Boston Globe, not talking at all about the fundamental issue that people are concerned about, that you're treating people differently, overtly. There's nothing implicit about this. You're overtly going to treat people different because of race, and just labeled that as that's white supremacists doing their thing, trying to get in the way of progress. And it was really, really disappointing to see. But just, I mean, the examples, and you've pointed out some examples in your book, but there's also this really concerning thing that's happened. One is that you have folks that are pushing forward this narrative that live in the academic / public health research community. They live in a bubble that they're well-intentioned. I'm sure they're well-intentioned, good folks that truly believe this, but they run around doing research that basically confirms their strong biases. And no one is going to point out this is the problem with it. These are the problems with it. On top of that, you have a media ecosystem built around them with many of the same biases that simply amplifies what it is they say. There's a ridiculous story in 2019 about an article that was published in Science Advances in 2019 that said that there was a correlation between police shootings of unarmed Black men and Black infants being born underweight and premature. Right? So this was done at Harvard. A Harvard sociologist published a paper definitively saying that unarmed Black men being shot, he did an analysis of the geography, and he looked at birth weights of Hispanics, whites, and black individuals, and he geographically, it showed that when you had a Black unarmed person that was killed, you had Black babies that were born underweight, but not Hispanic and not white babies. And I mean, that's, and that was automatic. I mean, again, to all of us sitting here, man, we would be like, I mean, the immediate response to that is, there's so many things that seem to be wrong with that, just on the face of it. Meaning, the first thing you do, I mean, if somebody were to publish a paper saying the sky is green, right, you would say, well, hold on now, right? And it's the same type of thing, like, and again, nobody said anything. This was Rhea Boyd, who is featured in your book, right? Immediately took the article, amplified it, and said, oh my God, look at this, more examples of systemic racism and why we have to fix, in order to fix preterm low birth weight Black babies, we're gonna have to fix police violence of unarmed men. I mean, it doesn't matter that, when I was having a discussion with a physician colleague about unarmed Black men dying, horrendous, of course, but I was trying to get a sense of scope. I was like, how many unarmed Black men do you think are killed by the police every year? And he said thousands. He said thousands. He thinks thousands of Black men every year are being killed in an unjustified fashion by the system. And all of us here know the answer is numbers in the 7, 8, 19. I mean, it's a small number of folks that's happened. It's terrible, but in terms of when you're talking about like, what do we do? Is this a systemic problem? I think it matters whether or not that number is 7 or that number is 5,000 a year. Correct? Yes. And this article that I'm talking about, that was published by Stat. I mean, that was reamplified by Stat, by Wired, NPR. It was all over, right? A Twitter user who's a data analyst in New York, a guy named Roman Jamiska. I think he has like 200 followers or something at the time. He said, this doesn't make any sense. He taught himself R, downloaded the code, which doesn't happen often, but the Harvard professor had put out the code, right? And he looked at all the IDs for the unarmed Black men that had been killed, right? And when he searched and tried to cross-index those with reality, what he found was that there was a ton of them were miscoded, right? Mm-hmm. They weren't. It wasn't an unarmed Black man that was killed for an unjustified reason, right? There was somebody that was anyway. So, and then when he told the author that, the author then reran the analysis, and it was a null result, and the paper was retracted. But it takes a random Twitter user a random person on Twitter who's a data analyst who's not sitting in, bathed in this propaganda and this little ecosystem, of media plus academic public health. That's what it takes in order to do it. And most of the time, the data for much of the stuff is not public, is not easily available, right? And so it's a huge problem. And so I really hope, I'm hoping COVID is the awakening for much of the journalist ecosystem to understand that you cannot simply go to some public health person or some academic researcher and say, what do you think of this? And have the academic researcher say, oh, well, the evidence says this. It's like, no, can you please, get some other views or get some understanding of science so you can actually, look at the paper yourself to figure this out, right?
Well, even for this paper I mentioned before, this Axios paper that I demolished one after another. Now, I grant you can demolish any paper. Right. There's no paper that doesn't have some issue in it that you can say, well, they didn't prove this, they didn't prove that. Yeah. The problem is, it's not so, even to me, the problem for the public is not so much that the papers are wrong. Even when the papers say what they say, the journalists then take them and totally screw up the story because they have a narrative.
Right.
I'll give you one more example, which I think puts out why this is really a problem. So there was a story in the Philadelphia Inquirer a while back about a study that was commented on through an editorial by two Children's Hospital researchers in diabetes. And the study was about the fact that minority children with type 1 diabetes had worse hemoglobin A1C levels than white children with, and which presumably reflected how frequently the minority children got an insulin pump. The two investigators at Children's Hospital wrote the editorial about it in the journal Pediatrics. And when they were interviewed by the reporter, they said, well, this is another example of racism and how this plays out. They're getting unequal treatment. What the reporter never mentioned was that it was an international study. The study was conducted in 3 cohorts. One was in the United States, one was in Switzerland, Germany, and Austria, and one was in New Zealand and Australia. And in each of those databases, the minority children had worse results in terms of hemoglobin A1C than the white children. So first of all, you never heard that it was an international study. If you read the newspaper article, if you read the review article or the editorial that they wrote, you found this out, but they still decided that this was racism. And then they cite a whole bunch of papers. So now if you go again, do this process of going back and looking at the citations, I had to go back 3 levels of citations to find the original paper which claims that bias has been shown in this particular area. And what was the evidence for the bias in the 3 publications prior? The evidence of the bias was a questionnaire that was given to endocrinologists that treated kids with type 1 diabetes and asked them, which kids would you use an insulin pump on? And the question was, would you differentiate between black and white children? The answer was no. They would not differentiate between black and white children. What was the basis for differentiating? It was the kind of insurance that people had. And then the discussion was, well, why would the insurance that the people had differentiate? Well, it turns out if you had Medicaid, the burden on the families was really great in reporting the 3 or 4 times a day glucose levels that needed to be measured in the kids in order for them to continue to qualify for an insulin pump. So this was a bureaucratic issue that led to less use of the pump, in the insulin pump in kids on Medicaid. In the international study, God knows what the differences are, but it doesn't speak to racism on the part of the physicians who are caring for these patients, even though that was referred to in one of the articles. In fact, it was, if you want to call that systemic racism because of the social conditions of the families, so be it. Call it whatever you want, but it wasn't the fault of the physicians involved here. And the journalist just totally elides over all this information and has an article that says Black kids are getting poor diabetes treatment. And so let's say you're a Black mother with your kid who's just been diagnosed with type 1 diabetes, and you're aware of this article, and you say, oh my God, my kid is going to be mistreated because of this racism. And that's not what's going on here at all. So and I wrote to the journalist, and her response was, I know your opinions on this, but there's bias in medicine, period. So the journalists aren't going to change. They're not, because they've got a narrative. they're as much ideologues as anyone else. You know, the Philadelphia Inquirer is as woke as any newspaper is gonna be, and this is another real problem in getting this information out to the public.
No, I agree with you, and then furthermore, you're always going to have, you know, research, quote unquote, trying to show that doctors are racist. You're not going to have research trying to disprove it, right? I mean, people are not going to give grants to try to show that doctors are not racists. So, you know, to try to make a level playing field, and so, you know, I mean, that's why, you know, it can be treacherous to. First of all, it's a constant work of having to debunk, right? I mean, it's constant. And number two, if you have any studies that maybe disprove what the argument is or show, then even those studies, I mean, as you said, you know, no study is perfect. One can always find, you know, a reason to, you know, to doubt the claims that the study that you want to use in your argument shows. You mentioned earlier about, you know, when we talk about the transgenders, you said that, you know, your organization would feel strongly that using hormonal treatment in you know, adolescents or you know, in children and adolescents, you know, is sort of crossing the line. But you said that it's because the data is not there to show that it shows benefit. But the problem is there is that you're not gonna. First of all, I mean, how can data? You can always produce some study that will show some benefit on some measure, right? And but it will always be sort of incomplete and insufficient. And on the other hand, I mean, I think, isn't there a case to be made to say, listen, I don't. I mean, it's not about what the data shows. It's about on principle, we know enough about human nature that on principle, kids should not receive hormonal therapy that will affect their reproductive systems and everything else. I mean, shouldn't we say that on principle, that it's you know, instead of trying to get into the weeds of scientific studies?
Well, you know, I guess my hesitancy to just make a blanket statement is, you know, it's not my field, you know, and I'm basing a lot of this on the fact that, at least as I mentioned before, in the European countries where experts have tackled this problem from a societal standpoint, which hasn't occurred in the United States. From a societal standpoint, they've made the decision that this is not something that should be encouraged. I think part of the problem, if you read some of the literature on this, particularly some of the journalists like Abigail Schreier, as I mentioned before, what's going on is just a total Wild West. I mean, these students are ending up in places where even non-physicians are recommending this, that their health plans in colleges, for example, or even in some private schools, are allowing them to get these medications. They're being given it sub rosa. It's just become something that isn't being dealt with on a societal level.
I'm sure. No doubt about it.
So I think it's more that. So I mean, if you ask me for a position as someone who considers himself a medical scientist, I can't just go out there and say, well, you know, there's no role for this at all. There may be a role. There's some legitimate physicians at legitimate institutions that feel very strongly that there's a role for this. The question is, should it be done willy-nilly the way it is being done now? And I you know, if you ask me personally, would I ban it just as a human being on the basis you talked about? Yes, but I'm not sure that, you know, I have a position that would allow me to make that statement and say that that's true under all circumstances. That's all. So it's a very difficult problem, but clearly this gender dysphoria becoming something that's leading to gender transitions is a new phenomenon. And whenever you see new illnesses, you worry about what the new etiologic agent is. And, you know, there's a big question about this being some sort of a mass hysterical phenomenon that goes on. And then suddenly children have been exposed to this and, you know, all hell breaks loose in their lives. I just encourage people to read Schreier's book and decide for themselves what they think about this.
So you said that you're taking this to court, or taking something to court. Well, you talk a little bit about what exactly you're doing with that?
Well, you know, again, when the government starts issuing edicts that go against the 14th Amendment, then that's the time that you know, legal remedies need to be invoked. And you know, right now there's a case in front of the Supreme Court that may upend an awful lot of so-called, affirmative action programs. And in Parents Defending Education, one of the groups that's been pushing back against the sort of critical race theory education initiative that's gone on in K through 12, they've really called some of these activities to a halt. So we're planning to file a suit about the Medicare rule that says that physicians ought to establish a critical race theory, anti-racism protocol in their practices. Because again, the leading proponents of this, the philosophers that are behind this movement, the Ibram Kendis and Robin DiAngelos of the world, say that anti-racism means discrimination, that the only way that it can be really initiated is to discriminate against the power structure, which means take white people, put them in an inferior power position to Black people, and that way you're going to have justice. And that's not America. That's un-American, and that's certainly not a professional view that physicians should uphold.
So it's interesting you say that, because it may be possible, or it's. I wonder what you think of the folks that say that we didn't realize it. I certainly didn't realize it growing up, but perhaps this is America, and this is what America has been set up to be since the 1960s. There was the Civil Rights Act of 1964 banned discrimination based on race and gender. So that's all well and good, but it grew out of this idea of unequal outcomes, disparate outcomes, right? And so part of the reason there's an awful lot of judges who've upheld a lot of different laws that have de facto, skirted around this issue of discrimination of one group versus the other to correct the disparate outcome. So in 1971, Griggs versus Duke Power Company, the Supreme Court ruled that intelligence tests, because they were not shown to be directly related to job performance, could not be used in hiring since Blacks scored lower on them. So it's basically, 1971 was 50 years ago. It's basically been the law, and there's a variety of different courts that have upheld various different versions of something like that, that have basically said that, standardized tests, if a test shows disparities, then it must be racist, right? And that vernacular is very familiar to everyone now. But it's almost like you're butting up against precedents since the 1960s and 70s.
Well, look, I'm no constitutional lawyer, that's for sure.
Yeah.
And I think the principle here is, it's one thing to say we have a rule that disadvantages one group and we're going to eliminate that rule. It's another thing to say we're going to produce a rule that disadvantages one group in order to benefit another group. And that's what, the Supreme Court is struggling with. And it may very well be that our case will be thrown out, but these are the sorts of fights that we're going to take on, because we feel like there's no place for that in medical care. This is basically a Marxist idea that there's only so much available for human beings. And if one group gets it, the other group doesn't get it. And it's sort of crazy in medicine. I think what's happened is, every time anybody really looks into what we can do to improve the healthcare of Black people, it turns out they're going to be able to improve the healthcare of everyone. One of the recent examples I saw of this is Penn decided they were going to have an initiative to improve maternal mortality in all of Penn hospitals, which is very low to begin with. And it's a very rare event, maternal mortality. It's like, in the worst case, it's about 30 cases per 100,000 deliveries. So it's a vanishingly rare event, really, but obviously something that you'd like it to be low. And it's much higher in the United States than in other countries. Well, to make a long story short, they realized that the reason, one of the causes, of course, of maternal mortality at the time of delivery, although it spreads out over several weeks in either direction, one of the causes is massive hemorrhage that occurs at the time of delivery. And what they realized is they didn't have a good protocol for dealing with it. They needed to have a team that was available whenever there was a large hemorrhage at the time of delivery, involving the blood bank and involving surgeons and involving a whole bunch of people that were on call, ready to come when there was such an episode. So the initiative for it was to do something about Black mortality. The outcome of it was to do something that was going to improve the situation for everyone. And, you know, that of course makes sense. And that, I think, is what we're going to find every time, that the way to fix some of the in-hospital problems, if to the extent that they do exist, will be to improve healthcare for everyone. And I think personally, I think the best way to improve the poor outcomes for Black people is to improve access for Black people. Telehealth may be a huge issue here. It may very well, I mean, there was a recent study also from Penn, where when they looked at people coming for return appointments after surgery, they doubled the utilization of the return appointments if they used telemedicine as the way that the patients were interacting with their physicians. So if some woman who's working 2 jobs to support her, you know, single parent family can't get off to go back to, you know, to visit the physician in a follow-up appointment, can do it at home at you know, 5 o'clock after she gets off work through her laptop or her iPad or her phone or whatever, that's going to improve care. So it may be that there'll be technological answers that will help some of this. And that's, if you ask me, what do you think is really going on with these poor outcomes? I think it's when, you know, the minority patients show up for their illness, they come in much later stages. They end up using more hospital care, more emergency room care than ambulatory care. When that gets fixed, and maybe telemedicine will have a huge impact on that, when we start to see that changing, that's when we know that we'll start to see improvements in outcomes.
Dr. Goldfarb, I mean, I think it's terrific. Your organization, I think, will have a great impact because there's none like it, and it's very important to sort of put the other side on on notice that we're not just you know, not just going to roll over and take the punches. Because you're absolutely right. I mean, you know, this whole ideology is racist in itself. Not just racist against white or non-minorities and what they're even racist against, you know, Black people. I mean, they're just racist. They foment racism. They perpetuate it. They solidify it. They make it explicit in many ways, and it's intolerable, and it should be called out and fought back. So,
yeah, and I think.
Yeah,
and yeah, providing an avenue for even just providing an avenue for transparency for what's actually going on in medical schools, in academic medical centers. I think that's going to be huge, because I think you know, in order to, you have to, yeah, I mean, it's a war, and you have to win. You have to win the culture war, right. And I don't think I think I'm with you. I think most Americans still have this idea that America should be colorblind. America should be a meritocracy. And you know, I think exposing things like you've done, exposing, you know, the thin evidence base, exposing the fact that affirmative action in medicine not only can be racist, but certainly, you know, it may not be the best way for you to choose the person that's going to be cutting it, you know, that's going to be cutting into your chest. I think that's, you know, incredibly important. So thanks for what you've done, and how, you know, again, it's so hard to do this, partly because medicine is so hyper-regulated. Medicine is so dependent on networks sometimes. It's incredibly rare to find folks like you who are willing to speak up and say it like it should be said. So thanks.
Well, I hope people will consider reading my book. Any proceeds from the book go piled back into the organization.
Good. We'll have a link. We'll have a link to your book. But what is the website for the organization? I think people should join and sign up.
Yeah, donoharmmedicine.org. It's one word. Okay. donoharmmedicine.org.
We'll have a link to that as well.
Great. Yeah, we have, as I said, I think we have about 500 people that have joined and 1,700 Twitter followers now after a couple of days. So hopefully, and we're gonna work hard as a voice for the people who feel that way. Yeah.
Great. Terrific. Thank you very much, Dr. Fugo.
Well, thanks so much. Great to see you all. Great. Bye-bye.